Next session. Effective physician-patient communication has been shown to positively influence health outcomes by increasing patient satisfaction, leading to greater patient understanding of health problem and treatment available, contributing to better adherence to treatment plans and providing support and reassurance. Topic for this session is communication skills.
The chairperson for this session is Dr. Jachin Velavan. She did her MBBS at CMC Vellore, completed her DNB Family Medicine in 2005. She did MRCGP from Royal College of General Practitioner, UK. She was awarded Best Doctor Award by Tamil Nadu MGR Medical University in 2012. She has worked for over 13 years in many rural mission hospitals in Orissa, Assam, Bihar and Tamil Nadu. She has authored more than 200 self-learning modules for doctors, medical students, nurses and community lay leaders. She was the head of the Department of Distance Education, CMC Vellore.
The speakers are Dr. Ramakrishna Prasad and Dr. Roshni Ganguly. Dr. Roshni Ganguly, she graduated in 2007 and started practicing in Bangalore and Kolkata in various renowned hospitals. She also did MRCGP from Royal College of General Practitioners, UK, and completed her PG diploma in geriatric medicine and diabetes. She has founded Aswin's Care Clinic to envision and dream of providing patient-centered and high-quality holistic health care. Internationally, she is involved with MRCGP South Asia as an examiner and is now a board member of MRCGP South Asia Board.
Thank you very much. And it is my privilege to chair this session. I know it's pre-lunch. Actually, we are very hungry, but there's going to be a feast. And so we have the best people who can give us a feast, a treat. So I promise that it will be a treat. So over to you, Dr. Arki and Dr. Roshni.
State conference will be there in Mysore. AFPI Karnataka State Conference is the flyer for that. Dr. R.K. sir is the president of AFPI Karnataka. He'll be announcing and inviting you all for the Mysore conference in another 15 days.
Yes, thank you very much. Will we be playing that now? You know, what we can do is, unless that is ready, we can play it just before you go for lunch. We have this thing and we'll do the communication skills workshop first.
Good afternoon, everyone. We're looking forward to an interactive session so that I know you all are hungry, and as Dr. Jachin said, that hopefully we'll have a useful session. So communication skills, it is said that a strong, therapeutic, effective communication skill, it really endorses a doctor-patient relationship, right? And it is also said that effective communication begins by listening and not speaking. So on that note, let us begin. So we are going to deal with the communication in day-to-day practice first. So for example, you know, we've discussed about what are the principles of family medicine and what are the different types of patients that can present to us. So generally, when in our medical school, we are taught about the normal flow of the consultation, okay, for any doctor. That is, the doctor comes to the OPD with a presenting complaint. You go on by eliciting the presenting complaint history, the past medical history, the drug history, examination, and then you write a set of investigations, and finally the treatment or the management. But where and how in family medicine or family practice can we make it different? And that is what our speciality is all about. So if we go through our consultation, now if we see that we've got a wide breadth of clinical problems that we deal with. Chronic disease management is one of the most common cases that we see. We have relatively independent decision making. Now, what I mean by that is when we are in community practice and we are in standalone clinics or in a group practice, we often have to take those decisions independently. And how do we make it effective is through better communication skills. And of course, it's not new that we have to deal with time pressures and Dr. Sunil Abraham today gave a wonderful talk on clinical uncertainty. So any patient that walks into our clinic, for example, a simple thing like fever, in the first visit when we are talking to the patient, we often deal with uncertainty. So considering that these are the 5 pillars of the consultation survival is what we say, and the family practice environment, how do we deal with it with better communication skills? Again, the tenets or the principles of family medicine, very importantly, as I said, communication skills endorse patient-centered care, which is the foundation of family practice. It is not disease-centered, it is patient-centered, and communication skill is an enabler to have an effective consultation. So it is personal, it is holistic, integrated, and of course, efficient. This is a case scenario, but we will come to some interesting role plays just after the brief talk, and then we will highlight to you each component of the communication skills, and we can have an interactive session. So this is just a general case. Day to day, patient walks in with the annual health reports, or comes in with fever, or comes in with abdominal pain, or for his diabetic checkup, whatever. The structure of the consultation or the style of the consultation can be implemented in such a way that at the end of it, it is both satisfying for the patient as well as the doctor. And we'll see how we can do that. So we know that, if we go through different books, there are very many consultation models that have been described, right from the beginning, from Balint and the one which is the latest, which is the Calgary-Cambridge model. But the 2 common ones that we often follow are, one is the Roger Neighbors model, which says that first, as the patient walks in, it is about connecting with the patient. Now, how do you connect with the patient, and how do you build that rapport? First is the greeting. The moment you greet, it's like an icebreaker, and then the patient comes up with an open, a question or the complaint. Now, very often we see that we tend to have this checklist in our mind where, we are trying to narrow down to the diagnosis. But in place of that, if we can start with an open-ended question and say, maybe a phrase like, how can I help you today? Then the patient comes up with the complaint. Following which, we can ask, certain closed-ended questions to come down to a particular diagnosis. Very important is to also understand the patient's ideas, the concerns, and the expectations, because here we are trying to have a structured consultation which will enable us to find out not only the problem of the patient, but we are following the biopsychosocial model. We are trying to understand the context of the patient. We are trying to understand the perspective of the patient so that we can effectively treat or manage the person. So connecting with the patient, it's often useful to summarize, because in family medicine, a patient doesn't walk in with one particular complaint. It is often 2, 3, or maybe 5 things that they would come to you. The doctor, I have headache, I have not been able to manage my job, I've been having a lot of stress, I have hypertension medicines, I have not been able to take it. So how do you remember so many things? So if you summarize at the end of the consultation, then it helps for you to remember and make a problem list in your mind so that you can prioritize and attend to each of the problems. Handing over or negotiating or giving the options to the patient. It's often said as shared decision making, where you're negotiating or understanding what are the options that can be given to the patient, and as per his or her feasibility, you come up with a plan for the effective management. Again, very important is red flags and the safety netting, so that if there are certain red flags, immediately that has to be addressed. If not, you at least tell them about the red flags, and if they do come up with those, they need to inform you, and that's a good way of a consultation closure or safety netting. And housekeeping. Now, housekeeping is seeing 30, 40 patients, 50 patients a day is not easy. So at the end of the day, you need to keep yourself well as well. So it's important that after each patient, you may take a 2-minute break, you may walk out, you may have your own way of getting into a relaxation mode, as well as preparing for the next consultation. So that is what is housekeeping. Calgary-Cambridge model, again, this on the same lines as we discussed, that you initiate the session, there's gathering of information, there is physical examination, there is explanation and the shared decision making, and then finally closing the session. Now, very important is, as I said, understanding the patient's perspective. If we do it well, then we have to express empathy. Now, may I just ask the audience, very simple question, that what is the difference between empathy and sympathy? We often use it together. Anyone, can you tell me what is the difference between empathy and sympathy? Yes, sir? Yes, so sympathy basically means you're pitiful, or you're expressing pity, whereas empathy is actually trying to understand what the patient is going through and take him through the process. That's wonderful. So what are the ways of expressing empathy? One is naming that, I feel that you may be having this. You name the problem and you express. Then understanding that, I understand that what you might be going through. That's a nice way to express that, what is your understanding of, empathizing with the patient. Respecting it, that, it must be really difficult for you to manage this kind of a situation that you're going through. That is, you're respecting the patient's problems and you're addressing it. Supporting is, of course, you're offering support that, I'll try my best to help you in any which way that I can. That is, an exploring is, again, that to find out how the patient is coping up and dealing with the situation. Now, that was about a general consultation that we can apply in every patient that we come that comes to our clinic. If we have this structured approach, I can vouch for it from my own experience, and I'm sure many people will agree with me here, that you wouldn't often miss the red flags, you wouldn't often miss out any important information, and you will be treating the person, the family, in a very holistic, patient-centered approach, right? Now, there's another kind of encounter which we might very commonly come across, is difficult patients. Now, what do we mean by difficult patients? That, for example, you have a busy OPD and you have 10 patients waiting outside, and there have been certain people who've been waiting for more than an hour or an hour and a half. So they just walk into your clinic and your chamber, and they just that, I have been waiting and my appointment hasn't been given well. So how do we deal with that situation so that we can address the patient's problem, the primary problem that the patient has come with? Because often what happens, we get confused and, we don't know how to handle the situation. There are certain barriers like your attitude, your, the inept knowledge of how to handle it, so that, the primary aim of treating the problem or the person, that goes in vain when you face these kind of difficult encounters. And there are different types of challenging patients. As I gave you one example, there could be there's something called dependent clinger. Now, these, very often than not, you would see patients who want your reassurance over and over again. And they're very insecure. They want to contact you on WhatsApp. They want to reach out to you for about the very small things. So they're very, very dependent on you, and they tend to cling on to you. That is one kind. Second is the entitled demander. That means very authoritative. They're very clear in their mind what they want, and they expect that out of you. So that is one kind of a difficult encounter. The third is the manipulative help rejector. So these people, it is seen very often that they are usually suffering from a depression, and they're seeking your help, but at the same time they do not follow what you are telling them. And the last one is the self-destructive, he just feels hopeless about him, that nothing can be done in his situation. And they often suffer from both anxiety as well as depression. So these are the challenging encounters that we may come across. Now, how do we manage it with communication strategies? First and foremost, very, very important foundation of good communication is active listening. You have to hear out the patient first. What is the patient trying to say? And then, after understanding, if you're in a wrong position, or you say that, okay, I'm sorry that you had to go through this, and thereon move on with his problems and tackle it in a very effective way. Second is validating the emotion and empathizing. Again, the same thing. So you validate, okay, the patient is, if it's an angry patient, okay, we validate that emotion, and we're trying to empathize and bring about a solution. Exploring alternative solutions, and mutually, finally, agreeing for a plan. So we will come up with that in our role play, and we'll demonstrate that to you. Again, this is a very useful protocol in an upset patient. So first is you identify which is the upset patient. Then you acknowledge that, you validate it and say, yes, you look upset. Let me try and make things better. How can I help? Then tell me more about, so you hear him out again, tell me more about, when you open up this question, then a minute or a minute and a half, the patient has his free will to express his thoughts, and that is very, very important in the first 1 minute of your consultation. And then patients really feel that they've been heard well, and the doctor understands problem. And better, absolutely not to interrupt the patient in this time. Then it goes on, as I said, that I'm sorry that it happened to you, and what would you like me to do to help you? And then you suggest and you agree for a mutual plan. So this is just a case scenario which I just discussed. Another, and the third one, is breaking bad news. Now, this is often a difficult consultation to do because of various reasons. Now, breaking bad news, we always try to associate it. Of course, if somebody walks in with a report of, say, a biopsy report, which is not good, or somebody having cancer, but it can be as simple as even getting diagnosed with diabetes for the first time. The patient may be in utter disbelief and will not want to is in denial and doesn't want to understand that he has diabetes. So how do you tackle that situation? Again, there is a very protocol structured way of approaching it. Once we do it in this way, and we keep on doing it with different patients of this particular group, then we get the hang of it, and you'll see that it just flows on its own. So here again, when you know that there's a patient coming in with a report, a bit of advanced preparation. So there's one mnemonic which says A, B, C, D, E. So you have an advanced preparation. You know that the patient is going to come in with the report, so you're mentally prepared. Now, building up this therapeutic doctor-patient relationship. Now, if you're seeing the patient for the first time, then you may want to ask about the history and why, and understanding of the report of the patient. What does he feel about the report? So that you are able to explain it better to him, right? Then communicate well. Again, nothing would happen without communication, so that's important. Now, once you break the news of whether it is diabetes or cancer or anything else, then you have to pause there for a minute to again validate the emotions. You don't know how the patient is going to react, whether he'll be angry, he'll be in denial, he'll be, you know, completely silent, he'll be crying. You don't know what is going to be the reaction. So you have to validate that emotion, then call in other family members, you know, and how much of information does the patient want to know? That's also an important thing before we break the news. They may say that, doctor, you know, I sent something really not right, so can I come in with my husband, or can I come in with my parents because I'm feeling very scared? So give it that bit of time for the patient to come in with, or you may want to make the patient wait while his relatives are coming in, or if the patient is again wanting to know everything about the report, you can share it, because we have to go back to our ethical principles again of patient autonomy, non-malfeasance, beneficence, and justice. So it is absolutely okay if we go on to discuss the whole thing, even if the patient doesn't want it, to respect the patient's autonomy. And finally, encourage and validate emotions and have a plan there, right? So this is just another way of handling it. Like we have ABCD, so here you have the setting, again the privacy, the confidentiality, that is very important, about what the patients understand, again invitation on information, then you express what problem he or she has, you empathize, and then finally you summarize. So that is called the spikes protocol in breaking bad news. This is basically the repetition. So we say that, you know, the calmer approach, this is again for difficult patients, that you find out at which point of change is the patient currently in, what is the patient's mood, or what is the patient going through. Then how do we try to alter the thoughts, listen, make that arrangement, okay? And then, of course, the education part. Now, most of us sometimes, you know, we want to just give an information overload when we are counseling people, because counseling is very much interwoven in all our consultations. It may be management, it may be explaining, it may be understanding the patient's concerns, anything. It's all interwoven. But sometimes we don't really gauge how much the patient is following what we are saying, and we just go on explaining and giving that information overload. So be careful about that. Take pauses. Try and see whether the patient is with you, and then proceed to the next point, right? So this is a case scenario. So I just wanted to just 1 or 2 slides just on the counseling, because people often feel counseling is more like, you know, just you have to share all possible information about that disease. Given to the patient, you know. So counseling basically, just to go through a definition as such, is a systematic process where the individuals, you know, they're given opportunity to explore, discover, or clarify ways of living more resourcefully. That's very important. So instead of forcefully just forcing the patient to just do this or instructing them, it is you are giving them options in a way that they could handle their situation better, right? And here also there's a generic checklist that first you explore. So it's a good way to start, you know, if the patient walks in with a report and say that, can I know why did you do the test? Or what is your understanding of the report that you have come in with? And then the patient begins, and then you give chunks of information in bits. And you check with the patient if he or she is on the same page with you, and preferably to explain in layman's terms is better than using any medical jargon, because then it again becomes very difficult for them to comprehend. So, elaborate on specific action, work out a plan, weigh the alternative solutions, summarize, and assure them of continuous support or continuing support, so that they can come back to you and, you know, go through all their problems and deal with the situations or the medical problems better. So I would like to end my talk with the famous saying of William Osler, saying that the good physician treats the disease, but the great physician is who treats the patient who has the disease, and that is what family medicine is about. Thank you very much. I would like to call upon Dr. R.K. to just take it on from here. Thank you.
Thank you, Dr. Roshni. Now we'll go to the role play. Can we have 4 chairs? Here. Yeah. So we have about 20 minutes. In the next 20 minutes, what we will do is we have 2 scenarios. This is okay. We have we have 2 scenarios, and can you give me the slide? The slide. Okay, we have 2 scenarios, and I just want, and this is the this is the process we will use. So what I will call upon each of you to do is observe intently. Okay, so we will have 2 scenarios. I invite Dr. Vivek and Dr. Sudipta to volunteer here, and Dr. Roshni will be the doctor, right? Yes. So this is extempore, but I want you to observe. And what I mean by that slide Ubuntu is that what I want you to look for is each one of them, no matter how well or how badly a certain encounter goes, will be doing several things which are excellent. So please look out, watch and make notes as to what did Dr. Roshni do which facilitated communication. If you can actually keep a piece of paper with you, that'll really enhance your learning. Just make a few points. Okay, over to Dr. Roshni and to Dr. Sudipta. And yes. And maybe you can just give a half a intro to what is the scenario.
So this is an 18-year-old boy who has come in with his sister with a particular complaint. I'm not revealing the complaint so that it is just you keep an open mind and we can explore. And yeah, they've just walked into my clinic and here we are.
Hello, doctor.
Hello, I'm Dr. Roshni. How can I help you today?
Doctor, today I have brought my brother who has been suffering from headaches since very long, and I'm really concerned about that. It has been almost 3 months that every evening that he's been experiencing headache and he complains about it. It has been troubling us a lot.
I understand. So, ma'am, you're saying that your brother's been, having headaches for some time. Can you tell me a little more about it in detail as to how it began and what happened thereon?
He would come back from school and then would complain that he's having headache, and it has been troubling him and he doesn't want to do his homework post that, and that has been troubling us because we have been receiving complaints from the school regarding it, that the homework is not complete. And when he says that this doesn't happen, like he has headache, obviously we have to let him rest, right?
Yeah, absolutely, yeah. So, can I know your name, please?
Hello, doctor. I'm Vivek here. So I study in 10th standard in St. Xavier School.
I see.
So my teacher has been very upset with me that I don't do my homeworks well. And my mother is also upset. She got me here.
Yeah. So can I understand from you that...
Great. This was fantastic. This was about a minute. So can we go around the room with some observations? There were several things that I saw Dr. Roshni do that facilitated communication. Can some of you pick out a few things that she did? Yeah, if you can just stand up and please. Doctor greeted the patient. Eye contact was there. Fantastic. Thank you. Others? If you can just stand up. Yeah. Okay, so she seemed to be listening intently. How did you make out that she was listening?
The doctor was nodding the head.
Nodding the head. How was her body posture? Leaning forward. Very right. What else was she doing?
She used to respond like,
Okay, yeah, she said. And what does it signal to a patient when you say It provides encouragement to speak further. Fantastic. Anything else that you noticed? Dr. Ramya's daughter, Krishna Smriti, right? So what did you notice? She collected medical history. Okay. How did she collect history? Open question. Sure. Anything else? Anything else that you noticed? I actually made a brief list here, and there were 9 points I wrote. She introduced herself. She said, "Who am I?" She greeted. Dr. Sudipta, who was the mother, greeted, and she greeted back. Then she let Sudipta speak. I noticed that she did not even interrupt her once. Dr. Sunil Ibrahim today made this point in his excellent talk on uncertainty, that we sometimes think patients will speak forever. They don't. You give them an opportunity to speak and don't interrupt. They are done in a minute or maximum minute and a half. Dr. Roshni did that in an exemplary manner. What else? I think many of you picked up on the non-verbal cues and body posture, leaning forward and nodding, the She also, after she listened to Sudipta, she used a very interesting technique. She used a mini summary. She said, so it sounds like this is what you have, and then invited her, can you tell me more? And again, let the patient speak. Invited her to give more details. And only then, after that happened, I noticed she switched her attention to the patient. And this gave the patient, you could see in the tone of Vivek here, the 10th standard boy, what he said, and he felt it sounded like a safe place to speak. So this was fantastic. How shall we do the second version of this? Shall we introduce some complexity here?
Yeah. Sure.
Okay. Now, what's happened to Vivek is Vivek has had multiple issues in school. We know that. Vivek is also angry. Okay? So, as we go back, Vivek will pick it from there.
So Vivek, you said that, teachers are not happy with you at school. Now, can you tell me what are the issues you're facing at school?
So there are a lot of messages going to my sister that I'm not attending classes. And so my friends also have been little naughty. So because we are in 10th standard, my teachers are worried that what's going to happen to our exams and things like that. So they've been going on sending messages to my sister and my mother. Now that is troubling me both at school as well as at home. Now, is there something that you could do about this?
Sure. You said that your friends have been naughty. Can you explain that? I mean, were you not able to attend classes? What was exactly happening?
No, that's the words that my sister and my mother are using, that they are naughty. I don't think they are naughty. I mean, like, we are all, I mean, like, we just go out, we go to, we get some guava and mangoes during seasons, and we just normal kids, you see.
I see. Ma'am, you were saying that he's been suffering from headaches. And Vivek, do you genuinely have a lot of headache and you've been facing that lately? Because can you tell me a little?
See, they've been asking me to study, and they've given me a timetable, strict timetable, so I get to play from 5 to 5:30, that's all. Right. Earlier I used to play a lot. I am a football player. Now they've cut down on my play time, and now I have to sit in front of books from 5:30 to 7:30. Now that is a long time for me to sit in front of books, and they have cut my TV time and phone also. They have kept it somewhere. I don't know. I'm searching for it from that time.
So whenever he opens his books,
what I don't understand is, why am I sitting here?
You're not able to figure out why you're sitting here. Now,
no.
Let me just put it in this way, that you, which is the more impactful thing? I mean, which is disturbing you more? Is it not being able to go for your football and follow your day-to-day practice, or is it the headache that's worrying you more here?
See, our tournament is coming up. I need to play football, but they're asking me to study.
Right.
Now this whole thing, and plus my friends are all going and playing. Their mothers don't say anything, but here they've been like, they are behind me for studying. Now I don't know whether this headache is because of not playing football or studying too much. We went to the ophthalmologist doctor also, and they checked my eyes and all, and they said it's normal. So I don't need any glasses. Now I don't know how to treat my headache now.
Right. So you are.
Great. Thank you. Please note, I mean, this is extempore. Dr. Roshni didn't know what they were going to say. I don't think Vivek knew what. This is fantastic. So now we have, as I see, there seems to be an understanding of the real problem. Can we identify a few things that we saw in the communication that might have facilitated that? Things that Dr. Roshni did, things that Dr. Roshni did not do, also some of the dynamics that we saw. Any observations, please? Okay, someone said something. She was not. How did you know that? What did you see that led you to that conclusion? Oh, fantastic, beautiful. So, so this word naughty came up. Dr. Roshni, not only was she non-judgmental in her affect, in the way she was looking, listening, speaking, but she also explored, what do you mean by naughty? So that was fantastic. What else? Yes. Okay, she perceived that there might be a conflict between the two people sitting in front of her. Did you see her do something or not do something to explore or give space to that conflict, for communication around that conflict? Sure, absolutely. By asking, so actually, what is really bothering? That's right. And there was, yesterday in the workshop on 3-stage assessment, Dr. Jachin was there. One of the wonderful things was, there are certain things which are easier to talk about. Like he said, I don't know why I'm here. In a doctor's office, sometimes it's easier to speak about things like headaches. And you can use that as the doorway to speak about deeper, more personal things. And we saw some of that here. What I'll do for the purpose of our instruction is I'll ask each of them how it felt when they were in the consultation. So I'll come to you last. I'll come to Vivek first. So Vivek, as a 10th standard student, how did it feel for you in the...
I think for the first time I feel that people are listening to me. Instead of being told what I should keep doing, you do this, you do that, I think I felt like, okay, they are at least listening to me. I don't know whether this will help me or not. The second thing is, it looks as if that I am they're worried about me. That there's something is kind of worrying, and they brought me here, and doctor is also listening to me, that I could understand something.
Thank you. Sudipta, as mother, how did you feel?
So I felt that the doctor heard me out fully, and she was also able to help us discover something that is bothering him deep down more than his headache. So we need to address that as well, that we do not dictate terms to him and tell him what to do, what not to do. So the interaction was opening up on real issues apart from what is physically surfacing for him in this regard. And I'm happy that she actually engaged him in the conversation. Otherwise, everybody just, the other people whom we visit, they just are concerned because I mentioned the headache. They're just concerned about the headache, and they just want to finish off with that with a few pills.
Great, great. And Dr. Roshni, how did it feel for you?
For me, as a consultation, I did feel that I could probably bring out the discord that was there between the 10th standard boy and his sister. And I could see the joy in his eyes when I allowed him to speak, which is quite satisfying for the doctor, because he came up with his actual problem of not being allowed to play football, and people are really dictating him and chaining him down, and that is not his area of interest. So we need to strike a balance and counsel the sister as well as the brother as to how we can mediate this.
Great, thank you very much. I think we had one more scenario of a family physician communicating with a specialist, but we might have run out of time. Okay. So I think decision is made.
That's non-verbal communication, as Dr. Jachin said.
Such effective communication. Okay, thank you all. Thank you.
Thank you so much, sir. I request Dr. Sunil, sir, to honor the chairperson and the speaker. Thank you, sir.